Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is gait disturbance. Gait disturbances are very common in the elderly people, and they are the cause for injuries due to falls and related morbidity and mortality. Gait is a complex phenomenon, and the normal gait is related to the coordination between the upper motor neurons and the lower motor neurons. As a matter of fact, there is sort of the communication between the central nervous system signals and the peripheral nervous system signals. Peripheral nervous system signals, they are sensory signals, they ascend and give the information to the central nervous system, that is the cerebral cortex. From there, command is initiated in order to carry on the voluntary act. Say, initiate the gait. So, the subtle disturbances in the peripheral as well as the central nervous system can cause the gait disturbances. In this class, we are going to touch about the pathophysiology of gait and various categories of the gait disturbance and the guidelines to the treatment of this problem. And also we touch briefly on the prognosis. Well, normal gait is dependent on the various components are involved in the normal gait. You should have the motor component, that means you should have the normal muscle with adequate strength, that is power and coordination, which is brought about by the motor neurons, which includes upper motor neuron, which extends from the motor cortex and the premotor gyrus, and the fibers extending from the nerve cells located in the motor cortex down to the anterior horn cell. And the lower motor neuron includes the axons extending from the anterior horn cells down to the neuromotor junction. And the power of the muscle is determined by the integrity of these motor neurons. And there are sensory component which carries the proprioception from the periphery down to the center. Taking the command related to the position of the body, proprioception is nothing but the sense of awareness of the body in the space. When you're walking, you're stepping forward, and the position of your limb is sensed by the upper motor, higher centers. Thereby, the command is sent down to the lower motor neurons in order to carry out the normal gait. Okay. Muscle strength is determined by the integrity of the upper and the lower motor neurons. Lesion anywhere in the upper motor neuron or the lower motor neuron can affect the power of the or strength of the muscle and thereby cause the disturbance in the voluntary act. You know, upper motor neuron lesion is associated with the loss of power with hypertonia and hyperreflexia and disuse atrophy. Whereas the lower motor neuron is associated with the loss of power with hypotonia and hyporeflexia, and the wasting of the muscle disproportionate to the disuse. Well, skeletal component, whereas coordination is brought about by the cerebellum. Okay, it is very important in order to carry out the voluntary act smoothly and perfectly. Skeletal component is the cause for any disturbance in the skeletal or the musculoskeletal or the joint diseases involving the joints can result in the non-neurological category of gait disturbance, which we are going to touch in the course of time. Sensory component, any lesion in the proprioception. That means posterior columns taking the proprioception signal can result in the gait disturbance. That results in the situation called sensory ataxia, which we are going to touch in detail in the various categories of the gait disturbance. Well, strength of the muscle, as I told you, determined by upper motor neuron and the lower motor neuron. And cerebellum helps in the coordination of the voluntary act. Well, gait is defined as the deviation from the normal walking or the gait. It is very common in elderly people because of the blunting of the various signals, which are very important in order to carry out the well-coordinated normal gait. It has numerous causes with variable presentation, and high index of suspicion of the cause is very important in order to understand the gait disturbance. Gait disturbance, again, it could be chronic or episodic. In a chronic category, patient has got the time to adapt to the situation, and they are not less likely to experience the injuries associated with morbidity and mortality. Whereas in acute or episodic type, which occurs all of a sudden, where the individual is not adapted to the situation. They present with the acute onset of freezing, festinating, or problem of disequilibrium. These situations result in the falls and injuries. Gait disturbance has tremendous effect on the lifestyle of the individual. It is very easy to understand. When the individual is unable to stand and unable to walk properly, it is going to cause lot of devastating effect on the lifestyle of the individual. Because he loses the freedom to carry out his own, activities, because it sounds embarrassing and is likely to sustain injuries because of falls. So that way, it has got a tremendous effect on the lifestyle of the individual. Well, the causes could be neurogenic or non-neurogenic. Neurogenic is common than non-neurogenic, which includes sensory neuropathies, chorea, subcortical vascular encephalopathies, Parkinson disease, dementia in elderly people, etc. Subtle disturbance due to any cause in communication between the central and the peripheral nervous system can result in gait disturbance. There could be there should be integrated function, that is well coordinated, well communicated function between the central and the peripheral nervous systems in order to carry out the normal gait. Osteoarthritis of the hip or knee associated with joint pain may result in the limitation of the movement, then cause the non-neurological gait disturbance. Under the neurological disorders, we have got the several conditions which may affect the central nervous system, thereby influence the peripheral nervous system. It includes Parkinson disease, wherein there is a movement disorder because of the defect in the degeneration of the nerve cells, producing dopamine in the substantia nigra. You have got the Huntington's chorea, which is autosomal dominant disorder. A situation called normal pressure hydrocephalus, which is associated with again the gait disturbance, dementia, and urinary problems in terms of incontinence. Sensory neuropathies affecting the proprioception results in the loss of balance, thereby resulting in gait disturbance. Subcortical vascular encephalopathy. Subcortical white matter includes the complex connections between the higher centers, which is the basal ganglia, and also the lower centers. Cerebral palsy, again, results in the motor dysfunction, resulting in spasticity, thereby resulting in gait disturbances. Muscular disturbances, muscular dystrophies. They cause the weakness in the muscle and thereby causing the motor dysfunction. In the same way, spinal muscular atrophies, ataxia-telangiectasias, ataxia-telangiectasias are the some of the inherited disorders leading to gait disturbances. Electrolyte disturbances. Hyponatremia is going to cause the weakness of the muscle. Secondary to the hyponatremia is a risk factor to develop the cerebral edema because of the hypotonicity of the fluid. There is movement of the fluid from the intracellular compartment to the extracellular compartment, thereby causing the neuronal damage. Hypomagnesemia and hypokalemia, they also cause the weakness of the muscles, thereby causing the disturbance in the gait. Coming to the epidemiology. Neurological type is common in men and non-neurological is common in women. It is said 80% of the persons at 60 have normal gait and only 20% have the normal gait at 80. That means remaining 80% at 80 or beyond 80, they are going to suffer from gait disturbance. Well, coming to the pathophysiology. What is gait? Gait is a cyclical event. That means it is gait cycle includes when you are stepping forward, the first limb is flexed at the hip and moved forward, and the second leg is at the stage of stance. That means physiology of the gait has got two stages: stage of stance and stage of swing. Okay, when the first limb wants to move forward, it is swing stage. That means from the stance stage, it is taking swing stage with the flexion of the hip, okay, and flexion of the knee, and forward movement of the limb with hitting the heel onto the ground. So cycle begins with the hitting of the first leg on the ground, heel on the ground, and followed by the second leg, flexing at the hip, moving forward, and hitting the heel on the ground. That means total gait cycle includes from the time the first leg hits the heel on the ground, with ends with the second leg hitting its heel on the ground. So in this phenomena, there is stance phase and the swing phase. That means when you are initiating the gait, the first leg from the stance phase, it is taking the swing phase, flexing the limb at the hip, moving it forward. And this movement, sense of this movement is carried through the signals of proprioception to the higher centers, okay? And command is sent to the second leg in order to maintain this position at the stance position, okay? And maintain the posture and stability of the body in the space. This is brought out by the signals sent from the vestibulospinal fibers okay, which plays a very important role in order to maintain the stability and the balance in addition to the cerebellum. Okay, so it's a coordinated act of the three important components in order to maintain the stability and the balance. That is vestibular, ocular, and the proprioception. They are the three important components to maintain the balance, besides cerebellum. Okay. Any lesion in these components can result in a gait disturbance because of loss of stability to maintain the body posture. Okay. Well, gait has two phases, stance phase and swing phase. Our stance is result of balanced reaction of the three sensory components. What are they? Ocular, vestibular, and proprioception. Gait's cycle begins with the touching of the first foot heel on the ground and ends with the heel of the second foot hitting the ground. Okay. After first foot hits the ground, there is hip flexion of the second leg, lifting the second foot off the ground and moving it forward with swing phase. Okay. Proprioceptive signals are sent from the periphery to the central nervous system, which identifies the position of the limb and sends efferent signals along the vestibulospinal pathway to the first limb in order to maintain its balance. Because one limb is off the ground, okay? You should get the signals from the higher centers to the second leg in order to maintain the stability and the balance of the body. Okay? Well, what happens during aging? Aging results in blunting of these signals and so the gait disturbances. Well, duration of the gait cycle depends on the velocity of the step. Based on the disturbances of the stance phase, swing phase, velocity, balance, posture, gait disturbances will be having variable presentation. Okay. You may be disturbed with regard to the swing phase. You may be disturbed with regard to the velocity of the gait. So you'll be having the frequent short duration of the cycles and you will be having short stepping gait. Okay, there could be sometimes hesitation. There could be trouble with the initiation of the gait, like that, so on, so forth, with regard to the clinical presentation. That all depends upon the site of the lesion and the pathology. Coming to the clinical presentation, we should get the complete clinical examination of the patient when they present with the gait disturbance. You look for the stance, how the stance of the individual. You look at the posture of the patient, okay, how he is standing, how he is initiating the gait. Ask him to walk, look for the initiating and the type of walking, and examine for tandem walking. Ask him to walk on a straight line with the heel touching the toes. Okay. Ask him to walk backwards and forward. Ask him to turn around. Okay. Examine for Romberg's test in order to understand the integrity of the ocular functions and the proprioception especially. And look at the gait cycle. Is it frequent, high velocity or low velocity? And you look for the step length and ground clearance of the foot. Is he freezing with regard to gait? Look at the arm swing, which is diminished with regard to the hypokinetic individuals with Parkinson's disease. Is he freezing because of the hypertonicity and the rigidity of the limbs. Look for the fast walking. If he's walking fast with short steps, that is fascinating gait seen in Parkinson disease. And look for the toe walking and also look for the blind walking. That means by eliminating the different components of the signals, you can test the site of the lesion depending upon the gait disturbance. Well, coming to the categories, we have got the antalgic gait, which is a pain is causing the gait disturbance. Because of the pain, there is a slow in initiation due to pain, whereas muscle power, tone, and reflexes are normal. Babinski sign is normal, sensory system is normal. Due to pain, either in the muscle or the skeletal, okay, or in the joint, the patient may not be able to initiate the walk, but other muscular power, tone, and reflexes are normal. Treat the painful condition, okay, and the patient will be improved. This is the antalgic gait. He must be having pain somewhere in the limb here. So this is usually characterized by uh, the patient will not touch the heel on the ground on the limb which is painful. He will have the flat foot, okay, hitting the ground with caution to avoid pain. And his toes will be on the ground with regard to the normal foot, normal leg. And the painful leg, he will place on the ground slowly with flat foot. That is the characteristic feature of the antalgic gait. Vaulting gait is common in children when it's associated with the one limb is shorter than the other, more than 2 centimeters difference. He walks with hip drop. Okay. So surgical correction with the lengthening procedure is curative. Look at this picture showing the gait cycle. Okay. You've got the stance phase, you've got the swing phase, and heel hitting the ground, and the swing phase, like that. You see, this is how the gait cycle is described. These are the various gait abnormalities you can see. Then coming to the neuromuscular or neurological causes. We got the Trendelenburg gait. Trendelenburg gait is nothing but the lesion in the gluteal muscles. Normally, while you're moving the limb, flexing the limb at hip, and from the stance phase, we are going to the swing phase, the hip on the first leg will be elevated. Whereas the lesions involving the gluteal muscle, that side of the hip is drops down instead of getting elevated. Okay. This is the characteristic feature of Trendelenburg gait. High stepping gait. This is seen in the sensory neuropathies. Okay. Or foot drop. It tries to clear the foot off the ground, keeping the step high from the ground. Scissoring gait is usually seen in the sort of the hypertonicity of the spasticity of the lower limbs. Ataxic gait, it is totally disturbed gait with a lot of incoordination. Patient is unable to initiate the gait, unable to maintain the balance. And the gait is so incoordinated because of the ataxia secondary to the cerebellar lesions. Sensory ataxic gait is secondary to the posterior column lesion. And hemiplegic gait is a sort of circumduction gait secondary to the hypertonicity of the muscles. Patient tries to lift the leg, okay, adducted the hip, abducted the hip, okay, and he tries to clear the foot off the ground. So he lifts and make an arching movement in order to proceed forwards. This is called the circumduction gait. Festinating and shuffling is short stepping gait. The velocity of the gait cycle is higher than normal, and he will have a rapid short stepping gait and stoops forward in order to maintain the gravity, center of gravity, in order to avoid the falls. This is a characteristic feature of Parkinson's disease. Apraxic gait is totally incoordinated, that is not incoordinated, it is patient is unable to initiate the, initiate the command. Command is sent from the center, but he is unable to initiate the act. He does not know what to do. We tell him to start walking. He does not know the command that is given to him, and feels difficulty in order to initiate the voluntary act. So this is the patient with Parkinson's disease. There are only to recall and make you to understand the various causes of the gait. That is, this slide shows a sort of repetition to know the various causes of gait disturbance. Just to go through that, the last one is hemiplegic or spastic gait, waddling or Trendelenburg gait in the hip lesions, Parkinson gait or fascinating gait, short stepping, rapid gait, which is very unstable, and patient stoops forward in order to maintain the balance. Then step-paced gait, commonly seen in foot drop, gait of sensory ataxia, cerebellar ataxia, which I told you, chorioacidosis and dystonic gait, seen in the a sort of hypertonic, hyperkinetic gait. Well, these are the various features of the different types of gait. What are they? You have to understand the different features. Trunk posture, stance, okay, postural reflexes, initiation of the gait, steps, speed, heel to toe, turning corners, Rambach test, heel to shin test, step falls. There are different conditions and the features in these different conditions, okay, as the features of these lesions at various levels of nervous system. Say cerebellar lesions, sensory disturbance, and cortical lesions. Okay, there are various, depending upon the site of the lesion, features for the gait disturbance. They have the manifestations. This picture shows the uh, clearly the various categories of gait disturbance. The first one is this spastic gait, a sort of hemiplegic gait or spastic gait. You say there is arching the lower limb, characteristic feature of circumduction gait. Scissoring gait, because the spasm of the lower limbs is working with the limbs close together because of spasm of the hip adductors. Propulsive gait is seen in the Parkinson's disease. Then step-paced gait is high stepping gait in sensory neuropathies, and waddling gait in hip lesions. Well, prognosis depends upon the cause. Those with mineral and vitamin deficiencies do well with correction, and the neurological disorders depends upon the treatment of the neurological disorder which is caused for the gait disturbance. And by and large, the prognosis depends upon the cause of the gait disturbance. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, bye bye.